Welcome. My name is Nicole Lewinsky. Today, I will be presenting on the Health Resources and Services Administration's cost of ambulatory care during 2017 through 2021 and detail the methods, results, discussion, and call to action for my analysis. Let's begin. The Health Resources and Services Administration, or HRSA, is part of the United States Department of Health and Human Services. The focus of the HRSA is to aid individuals who are underserved in a medical, economic, or geographic capacity and ensure their access to quality and reliable healthcare services. This includes individuals living in rural and remote communities, low-income residents, pregnant women, Alaska Native and American Indian groups, and those who are living with HIV. The cost of ambulatory care refers to all expenses related to providing healthcare services at an outpatient level, not just the cost of a patient appointment. An analysis of HRSA data is necessary to connect the cost of healthcare to patient outcomes. In measuring the cost of ambulatory care, we can have a better understanding of where the most cost-effective care is being delivered and identify areas where higher expenditure occurs. The purpose of my analysis is to take a deeper look into how the management of chronic conditions like hypertension and diabetes affect the cost of outpatient care. Cost is essentially the bottom line for managing chronic conditions. So finding ways to reduce the cost of care while improving outcomes reflects true value for population health management. For my HRSA data analysis, I was able to draw connections between the volume of patients, average cost per patient, and the controlled rates of hypertension and diabetes during 2017 through 2021. I then analyzed the data to see how the relationships changed during that time period. Merging all the data into visualizations helped me synthesize my findings into a better understanding of the HRSA data as a whole. The data used for my analysis was collected from the HRSA National Health Center Program Uniform Data System, or UDS, awardee data. This data is accessible to the public on the hrsa.gov website. I used multiple variables in my analysis of HRSA data. My first visualization looked at the number of total patients nationally versus the average cost per patient for 2017 through 2021. The second visualization compared the rate of hypertension and diabetes to the controlled rate of hypertension and diabetes for 2017 through 2021. My third visualization displays the average cost per patient versus controlled hypertension in the top 10 and bottom 10 states from the continental United States, Alaska, and Hawaii, displayed by average cost per patient for the year 2021. I chose these particular variables to learn more about the balance between costs and quality of care for HRSA health centers. The national trends were chosen so I could analyze patient volume and efficiency data during 2017 through 2021. The state-level data helped analyze the differences in control of hypertension and average cost per patient during 2021. For my data analysis, I used Tableau Public version 2025.2 and Excel in Microsoft 365 version 2507. While preparing my analysis, I noticed there were some values in the Excel dataset that were blank. I did not have any null indicators appear in my Tableau worksheets and visualizations. To be sure these fields were recognized as non-existing data, I set the special values format to blank text and show at indicator marks. For this data analysis, all HRSA patients from 2017 through 2021 are represented here as the total population. The metric population for this data analysis includes all of the subgroups of the total population, such as the hypertensive or diabetic patients, the controlled rates of chronic disease, and the average cost per patient. The only assumptions made pertaining to the data included in my analysis is that all values reported in the HRSA Uniform Data System have been accurately reported each year, and all HRSA health centers have taken care not to introduce any bias that could negatively influence my interpretations of the data. Two limitations I would like to mention are HRSA variables and patient data. For my data analysis, I was able to aggregate the data, but this was limited to select variables. Also, the HRSA data is reported by state and health center, not at the level of the individual patient. This visualization shows the total number of patients and the average cost per patient from 2017 through 2021. The values on the left and the blue line represent the total number of patients nationally, and those on the right and the orange line represent the weighted average cost per patient. Based on this data analysis, we can say the number of patients steadily increased from 6.8 million in 2017 to 7.6 million in 2019, then decreased to 7.3 million patients in 2020. In 2021, the number of patients increased to 7.5 million, which is nearly what the count was in 2019. We can also say the average cost per patient increased from $1,237 in 2017 to $1,370 in 2019. Between 2019 and 2021, the cost per patient increased from $1,502 in 2020 and $1,612 in 2021. This data analysis shows there is a relation between the variables for 2017 through 2019 and 2021, but an inverse relation during 2020. During 2017 to 2019 and 2021, the total numbers of patients increased and the average cost per patient increases as well. In 2020, the number of total patients decreased and the average cost per patient increased. This next visualization shows the rate and controlled rate of hypertension from 2017 through 2021 on the left and the rate and controlled rate of diabetes during the same years on the right. The blue sections represent the chronic condition prevalence rate, and green represents the controlled rate of the chronic condition. Based on this data analysis, we can say the rate of hypertension was 27% in 2017 and 2018 and rose gradually each year to 30% in 2021. The rate of controlled hypertension stayed the same during 2017 and 2018 at 63% and increased to 65% in 2019. The percentage of controlled hypertension decreased from 65% to 58% in 2020 and increased slightly again to 60% in 2021. We can say the rate for diabetes was 15.06 in 2017 and rose very slightly to 15.27% in 2018 and 15.35% in 2019, then decreased to 14.74% in 2020 and increased again to 15.35 in 2021. I would like to point out that I included 2 decimal places in the diabetes rate percentages because without them, the calculated field appeared as 15% for all 5 years. Controlled diabetes remained the same during 2017 and 2018 at 67% and rose slightly to 68% in 2019. The control rate decreased to 64% in 2020 and increased to 68% in 2021. We can say this data analysis shows there is a relationship between the hypertension rate and hypertension control rate from 2017 through 2019, as percentages remained the same in 2017 and 2018, and both increased in 2019. In 2020, the pattern changed when the rate of hypertension increased while the control rate decreased, and then in 2021, both hypertension rate and control rate increased. We can say there is a relation of stability between hypertension and diabetes rates during 2017 through 2021. The stability pattern is minimally affected in 2020 when the rate of diabetes dropped slightly. However, it trended upwards again in 2021. We can also say analysis of data shows a relationship between the diabetes rate and control rate from 2017 through 2019, where the diabetes rate was stable around 15% and the control rate was between 67 and 68%. The diabetes rate and control rate followed the same pattern of a drop in 2020 and increase in 2021. We can also say from this data analysis that there is a strong relation between the control rates of hypertension and diabetes with stable prevalence during 2017 to 2019, a decrease in 2020, and then another increase in 2021. This visualization displays the HRSA data for the average cost per patient to the controlled rate of hypertension during 2021. The chart on the left shows the top 10 states filtered by weighted average cost per patient, and for comparison, the chart on the right shows the bottom 10 states. Based on this data analysis, we can say in the top 10 states, there is a range in the average cost per patient of $1,382 in New Hampshire that increases to $4,180 in Alaska. There is a range in the percentage of controlled hypertension of 56% in both Alaska and Hawaii that increases to 66% in New Hampshire. We can also say that based on this data analysis, in the bottom 10 states, there is a range in the average cost per patient of $775 in New Jersey that increases to $943 for Indiana. There is a range in the controlled hypertension rate of 51% in Alabama that increases to 65% in Kentucky. We can see from this visualization that there is an inverse relation between the top 10 states and bottom 10 states. The trend line in the top 10 states chart moves in a downward direction as the average cost per patient decreases and the percentage of hypertension that is controlled increases. The trend line in the bottom 10 states moves in an upward direction as the average cost per patient increases and the rate of controlled hypertension increases. Now let's apply the visualization results to chronic condition management at HRSA Health's clinic level and discuss the impact on public health. The first visualization showed a comparison of the total number of HRSA patients to the average cost per patient during 2017 to 2021. I believe the sharp decrease in the number of total patients while the average cost per patient continued to increase in 2020 are solid indicators of how the COVID-19 pandemic influenced community health centers across the United States. One possible reason for the decrease in patient volume was that individuals were encouraged to stay home so the coronavirus didn't spread, especially at the beginning of the pandemic. According to a report by Corello and Tolbert in 2020, patient visits to community health centers decreased by 43% during the pandemic because individuals avoided in-person routine care. The same report indicated that at least 1,954 health centers had temporarily closed by early May in 2020. The cost of delivering ambulatory care continued to increase even with the decrease in number of total patients. A study by Wright et al. In 2021 confirmed that during the COVID-19 pandemic, community health-based centers encountered higher costs per patient with a reduction in patient care, especially those in rural areas. Wright et al. In 2021 concluded the fixed operational costs of community health centers, such as implementation of safety supplies and protocol expansion, staffing and workflow inefficiencies, and the transition to or expansion of telehealth services also contributed to the increase. The second visualization showed the hypertension and diabetes rates were stable between 2017 and 2021, with only a slight decrease in the rate of diabetes in 2020. The percentage of controlled hypertension and diabetes were stable from 2017 until 2019, and both dropped significantly in 2020 and began to increase again in 2021. Hypertension and diabetes had a consistent presence during 2017 through 2021, and I believe this shows the prevalence of both chronic conditions in the same population of patients. I think this visualization also helps support the idea that the decrease in both controlled hypertension and diabetes percentages only in the year 2020 is related to difficulties in managing chronic conditions across the entire HRSA population during the COVID-19 pandemic due to a reduced access to care. A study conducted by Shaw et al. In 2022 supports the idea that a decrease in number of in-office check-ins with healthcare providers during the pandemic was due to decreased access. When patients experienced a reduction in the number of in-person visits with their healthcare provider, essential chronic conditions management tools were negatively impacted as well, including follow-up assessment, adjustments of charges to medications, and patient education. The third visualization showed an inverse relationship when comparing the average cost per patient to the rate of hypertension control access across the top 10 and bottom 10 states. In the states that had the highest control cost per patient, the blood pressure control rates were between 56 and 66%. On the other hand, the states that had the lowest cost per patient had blood pressure control rates between 51 and 65%. I believe the visualization supports the idea that greater spending and higher costs per patient do not necessarily ensure there will be better control of hypertension. There may be additional factors to consider in the higher cost states, such as the overall cost of living, the location of the HRSA health center, and other health needs of the HRSA patient. I believe the visualization also supports the idea that the states having a lower average cost per patient with high rates of hypertension control should be studied to identify HRSA health center best practices. A study by Beckman et al. In 2023 confirmed that primary care health clinics that used a teamwork approach to identify other high control, low cost clinics, the improved coordination of healthcare resulted in better outcomes for chronic conditions and reduced costs. Now let's move on to what can be done to solve problems. In early 2022, Wright et al. Reported that during the COVID-19 global pandemic, 15% of HRSA health center sites closed. More than 10% of HRSA staff did not have the ability to work, and there was a major shift from in-office patient visits to telehealth for more than 50%. The data supports the idea that many HRSA health centers were simply not prepared for the COVID-19 pandemic. Moving forward, it is important to identify HRSA health centers that may not be performing at their best and use the data and research to streamline individual HRSA health center operations so we can continue to improve patient outcomes and reduce the cost of ambulatory care. When improving the efficiency of operations, some additional funding will be necessary for conducting a thorough assessment of current workflow and to find waste. According to Wright et al., involving HRSA staff in this effort ensures future changes are realistic and sustainable and shows the staff their input matters. A feeling of inclusion contributes positively to healthcare team morale and can ultimately increase employee satisfaction and retention. Wright et al. In 2022 also stated the involvement of healthcare workers in the identification of inefficient workflow helps to build strong workplace culture, strengthens individual accountability, and results in long-lasting improvements. Strengthening and growing HRSA telehealth services will not only improve community access to care, but also aid in ongoing efforts to improve chronic condition management. Shaver in 2022 reported that prior to the COVID-19 pandemic, HRSA telehealth services were very limited because insurance reimbursement was sporadic and healthcare providers could not practice across state lines. The visualizations we looked at earlier showed there was an improvement for both hypertension and diabetes control rates after a disruption occurred, such as the pandemic, and according to Shaver in 2022, reinforces the idea that telehealth services should most definitely be used in chronic condition follow-up care and will ultimately contribute positively to sustained control rates. And to support the use of telehealth, it is important to note that in 2022, Shah et al. Reported data on telehealth in chronic conditions as follows. 9.9% of individuals with chronic conditions receiving telehealth in 2018 and 59.2% in 2020 and 54.9% in 2022. HRSA health centers can learn best practices for care delivery and the management of chronic conditions and from one another, and not just high cost, high control states learning from low cost, high control states. When innovative ideas and insights are shared about what strategic measures are working or not working, all HRSA health centers will improve its workflow process to deliver excellence in healthcare. Beckman et al. In 2023 encourages the top performing HRSA health centers to share its strategies on successful management of chronic disease to allow all HRSA patients to benefit from the delivery of high-quality care. Beckman et al. Further stated this type of information sharing across HRSA health centers can help reduce gaps in performance and promote consistent healthcare practices across all HRSA health centers. This concludes my presentation. I have included all references that were used in my data analysis and presentation here for your information. Thank you for your time today.